Well, thank you very much. Can you hear me all right? Does that sound reasonable in the back? It's a pleasure to have been invited to give this lecture. I really appreciate you all being here and listening to what I'm going to present today. Feel free to ask questions as we go along. I'm going to cover some things rather quickly and leave some time at the end also for more protracted questions. So I'm going to be talking about deep brain stimulation for psychiatric disorders, which is something of a new area for us in neurosurgery. But I'm going to set it in a historical context because there have been surgeons, certainly in the last 100 years and even before that, trying to solve psychiatric problems with surgery. And so I'm going to sort of place it in that context and then go on to some of the more modern things that we're doing with deep brain stimulation. So since antiquity, people have attempted to do surgery, even, thank you very much. Okay, great. So, they have found trephined skulls from as far back as 5000 BC. This is an Inca skull that was found. There have been others sort of found throughout the world. In the 1600s, people did surgeries again to release bad humors or spirits, which were often thought to be psychiatric diseases that they didn't understand how to treat. As we entered the 1800s, people were just beginning to understand that different parts of the brain contain different functionality. And so the earliest attempt at that was phrenology. This is sort of has become semi-famous, that people would look at the bumps on the skull and figure out whether you were, prone to, this disease or that disease, or deep thought or frivolity or whatever it was. But that's not too far off. Really what we came to understand not long later was that there are very particular parts of the brain that are involved, particularly in judgment and frontal processing. And so one of the opportunities for that was this very famous individual, Phineas Gage, who had a bad injury here, shown this, with a tamping rod that was accidentally, he was a railroad worker who had a rod that was exploded and thrust through the skull. I'll take that picture off, I know it's somewhat disturbing. But he survived that and had an altered personality. He was otherwise completely normal function, normal language, etc., but his personality was significantly altered. And so that case and cases like that began to suggest to people that individual parts of the brain were important for individual aspects of function, be it judgment, and that parts of this may contain things like schizophrenia, depression, OCD, etc. In that same era, Paul Broca began to understand that language was actually localized in particular parts of the brain. And so through examining patients who had had very focal strokes in one area or another, he was able to parse out where language is principally processed. And this really opened the door for a much broader exploration of what areas of the brain do. And here are some of the individuals that were involved in that. So maybe the most important of these is John Fulton here. He was a researcher and the head of the neuroanatomy lab at Yale. And what he discovered in primates was that different parts of the brain could be lesioned or altered in order to treat aggression, to treat compulsive behaviors. And he famously presented this work at the Second World Congress on Neurology. And that seems to have been sort of a meeting point for some of the great minds at that era. So people that I'm going to talk about, Menis, Freeman, Watts, were all present at this one particular meeting, and that seems to have been the genesis for what was something of a revolution in thinking about schizophrenia and psychiatric disease and its potential treatment by surgery. The first individual to attempt surgery for psychiatric disease was this gentleman, Gottlieb Bruckhardt. And really quite early, actually before that meeting in '91, he reported a series of cases in which he had drilled holes in the skulls and lesioned parts of the brain which were felt to be involved in schizophrenia. And he had in that first series of 3 successes. It's not quite clear how it was measured, but 3 successes, 2 partial successes, 1 death. And you see his quote at the bottom. I mean, history is in some way made by zealots. I mean, he was clearly somebody who believed very strongly in this and was willing to sort of take this on. He and his patients were willing to take this on at some cost, obviously. This statement, I think, sounds frightening today. Anyone who reads that today thinks that's just a terrible thing to suggest to do to patients. And it helps, I think, to put it a little bit into context. I'm missing one of the pictures here. There. Put it into context. So in this era, to understand why people were willing to do such terrible things early on, when we really understood so little of the brain, it's important to understand what was the what was the current realm of psychiatric treatment? Well, at that time, there were really very few medications for treating psychiatric disease, and particularly schizophrenia could not be treated by the medications that we've enjoyed since the 1950s. And so what they had were restraints, immersion baths. They could cause seizures, which was sort of the preamble to ECT. By causing a seizure with an insulin coma, you could essentially create an ECT, electroconvulsive therapy. You could shock the brain essentially into potentially reversing some of the aspects of disease that it had. But really there was very little, and many of these patients, there were about 500,000 patients in the US held up in asylums where they were pretty much just restrained. Thank you. That's great, thanks. So I think understanding that gives you some sense of what the justification was in these people's minds. They couldn't stand by and do nothing, even if what they did was not, was imperfect by modern measures. The most famous individual surgeon to take on psychiatric disease is this gentleman here, was Igaz Moniz. He was a Spaniard. He was born in the late 1800s. He was quite a prominent individual in addition to really standardizing the first frontal leucotomies, which were where they essentially cut some of the white matter pathways to the frontal lobes that were implicated in these diseases. He also invented cerebral angiography, so when we get pictures even today of the carotid arteries and the arteries in the brain, that was something that he invented. He won the Nobel Prize really for both of these inventions, although today they kind of downplay the psychosurgery part because that's become such a, such a negative connotation. But he presented this work and had 14 successes out of his first 20 leucotomies, and for patients for whom there was really no other treatment, this was a dramatic success at the time. This was taken up by a number of individuals throughout the world. In the US, this team, Walter Freeman, who was a neurologist, and James Watts, introduced leucotomy to North America. And they modified the procedure somewhat. So what Watts really invented was this procedure here. And what they would do is they would make a small opening on the side of the brain here, and they would insert this, just a blunt knife that would make these cuts, and that would essentially divide out the frontal portions that were causing the schizophrenia from the rest of the processing. And this is done with some success. So, in 1942, they reported 200 patients, and 63% of these showed clear improvement. Again, in this era, really, there were not great measures. We didn't have standardized scales and outcome measures and such, but they did show significant improvement. There were also significant complications. About 14% had seizures, apathy, confusion, any of a number of things. And that was, I think, a frustration at the time, but didn't preclude them from doing the procedure given the severity of these patients without surgery. So Freeman really was another sort of a zealot. Although just a neurologist, he quickly took on doing some of these procedures himself. The neurosurgeon couldn't keep up with him and all the patients that he wanted to treat, and so he invented a way that essentially every physician could be their own lobotomist, he said. And what he determined was that, well, with sort of a special ice pick device, which is what it was called, the ice pick procedure, you could lift the eyelid and actually make these projections into the frontal lobe. And, you could do this without any real surgical training. It was simple enough. And so here he is. This is the truth is sometimes stranger than fiction. It's hard to believe anyone would do this. He went on doing this and actually got a Winnebago that he would drive around the country in, and he would go from place to place and do these procedures by the hundreds. I mean, he would pull up at an asylum and do hundreds of these. And he was not alone. I mean, so really, in this era, sort of up until the 50s and 60s, there were thousands of these done. And again, most of these were done for quite good reason. There were patients who were so sick that they otherwise wouldn't be able to survive in society, couldn't leave the asylum, were always restrained. And so if you look at the summary of that, the best report on it is Tooth and Newton, and they reviewed actually 10,000 charts. So it's a huge number by any neurosurgical standard, huge number of patients. And 70% showed, very significant improvement. There was a high mortality rate, 6%, 1% epilepsy rate, and then marked disinhibition. So, changes in personality that were quite frustrating. But so this continued really until the mid-50s, and there were several things that curtailed it. The most important event that curtailed these sort of procedures was was chlorpromazine. So suddenly with the advent of drugs that could treat schizophrenia, later Haldol, you really didn't need to do these surgeries. So today most patients who have schizophrenia are very well treated with medications. It's a very, very small subset of patients with psychiatric disease that would need any surgical intervention. That was not true at the time. There were also some very prominent cases that caught public attention. So Rosemary Kennedy was, I believe, the youngest of the Kennedy daughters who underwent a lobotomy for disinhibition, maybe a questionable indication for her. And so that was one that sort of caught people's attention, that she would undergo a lobotomy. There was also One Flew Over the Cuckoo's Nest. Have people seen that movie? So you remember at the end he has this surgery and he comes out and he's kind of completely apathetic and staring off into space. So movies like that suggested to people that this maybe was not the best way to go. There was in the 60s a bit of a furor over this based on some of the stuff I've showed you and some other things I'm not going to go into. But in 1977 this actually rose all the way to Congress, and there was a National Commission for the Protection of Human Subjects that had convened a hearing on psychosurgery and reviewed all of the data and all of the complications and all of the liberties that were taken with it. And what they said at the end of this, they said, we looked at the data and saw that they did not support our prejudices. We saw some very sick people had been helped by the surgery, and the operation should not be banned. At that time, they recommended that IRB approval be used for any surgery like this that's going on, something that we do use today. And they suggested the creation of a National Psychosurgery Advisory Board. That's not ever been created, so we are still not at the point where we have a national body that regulates this. But individual institutions like Vanderbilt are, do this only with the greatest trepidation and concern, and making sure that we're really doing this for the best reasons and intentions. So I'm going to talk to you, that was sort of the backdrop. I'm going to talk to you today about sort of what has been done in the last 20 years and what we're doing today in the context of this sort of history that obviously we're all very concerned about when you think about moving forward into this area. So what is the magnitude of the problem? So usually, I'm in a neurosurgery department. Most of my colleagues are treating tumors and aneurysms and strokes and this sort of thing. So I have to really convince them that depression and OCD is something important. They don't usually, it's not as exciting as an aneurysm, I guess. So in 2000, there were, almost 30,000 people that died by suicide in the U.S. The great majority of these are patients who have depression or OCD. In aggregate, mental illnesses accounts for about 2.5% of the GDP in the U.S. And if you look at the WHO reports on the greatest causes of disability, and depression is right at the top of the list. And if you actually look at the top 10, 4 of those are psychiatric diseases. So depression and the other psychiatric diseases outweigh all cancers put together, although we typically think of cancer as being the most terrible thing. These are really the greatest contributor to human disability in the U.S. and throughout the world. And this is true even with all the great medications we have. Up until the 50s, we really didn't have any medication to treat these problems. Today, we have very good medications with Haldol and more modern antipsychotics and antidepressants. We're very fortunate to have that, but there's still a substantial population that are not well treated by those. And for the most severe, the patients who have been through 3 and 4 medications and are still quite disabled, that's where we begin to consider these types of interventions, and we do it very rarely, a handful of patients. So, sort of the second wave of treatment, so leaving the lobotomies behind, which are not performed anymore and no one would consider, when do we consider psychiatric surgery and how is it done? Well, in the time from the 60s and 70s up till present, we began to understand that a particular circuit in the brain, the Pepez circuit, involves limbic parts of cortex, these sort of emotional parts of cortex, and links them in a number of circuits. And around this time, a number of individuals, the most prominent being Spiegel and Weichs, came up with a stereotactic frame. And you can see the first one that they had was a very crude device, sort of a plaster cast that could be put over the head. X-rays could be taken to sort of show what the delineation of the skull is, and they could use that to pinpoint anatomy in the brain and lesion it. And so instead of doing these big leucotomies that you saw, they made very specific lesions. So we knew that this Pepez circuit and the cingulate gyrus here, this part of the brain, is implicated in OCD and depression. And they made very, very focal lesions in that structure. And so here you can see this is an MRI showing a modern cingulotomy. And so these are still lesions. This is not DBS yet. But this began to suggest that these procedures could be done very focally without very significant side effects or problems, without changing people's personalities, without making them apathetic, without causing seizures, etc. And a number of other procedures have been done. So there are capsulotomies. It's another part of the brain with white matter fibers that connect different emotional parts. And something called a subcaudate tractotomy or limbic leucotomy. This is just another part of the brain that involves these different areas. So we've been able to identify essentially nodes of activity that seem to be critically important in depression, in OCD, and in schizophrenia. So we've really just begun to understand what these parts of the brain are doing. Functional MRI has added a whole other layer on top of that, so we can see not just where these parts of the brain are and what they are anatomically, but what they are doing functionally. So we can test patients who have depression and see how their brain changes in its activity when they are appropriately treated, when they're not treated, when they're very sad, etc. And we can pinpoint areas and say, okay, that's the spot that seems to be involved in uncontrolled depression, and let's see if we can't alter that in some way. So for about 20 years ago, enter onto this deep brain stimulation. And so we do quite a lot of deep brain stimulation for movement disorders at Vanderbilt. And I'm going to show you, I'm just going to play some of these for you. I had all the data here, and I thought, well, it's just going to be more interesting to see the patients. So let me show you. Okay. So what you're seeing in the top is a patient with Parkinson's disease. You're going to see him first off of his medication and without stimulation before his surgery, and you're going to see how he's improved. You can see he's very stiff. At the bottom is a patient with dystonia. This is a disease where you have protracted contraction of the muscles that you cannot control. You can see that this woman, her head is forcefully turned and rocks in a way that she can't control it. And then you see her after surgery. She's been given a very fancy haircut that we provide as part of the procedure. But you can see that she's completely straightened out there. And so I'll show these just for a minute. I hope it doesn't take too long. But what we're doing in these patients essentially is making use of similar anatomy. We know that I showed you the circuit that underlies psychiatric disease. There's a similar circuit that is related to it that underlies motor disease and regulates whether you are too stiff, as in Parkinson's disease, or you have too much movement, like this patient who's sort of rocking and contracted on one side. And so we've begun to understand that if you have a circuit like that and you can put an electrode in it rather than lesioning it, we don't like to lesion the brain if we don't have to. We'd much rather put an electrode there and try to affect it with electricity, jam that circuit reversibly so that you do something there that you can turn off if you have to, or adjust if you need to stimulate it more. And you can alter that circuit just enough to rectify the problem in many cases. So this one on the top takes a little while. Now you can see he's being turned on for the first time, and you can see. So suddenly, now that his stimulator is turned on, he was very, very frozen and stiff before. Now he's able to move his hands very easily. Here he's able to do whatever he's doing there. I think he's being asked to do that, although that may be spontaneous. I'm not sure. And you'll see him walk, and his walk is also improved. So in both of these diseases and in others like essential tremor and such, we can get really excellent results with stimulation. And so we've begun to have a new technique that allows us to intervene in brain disease without lesioning those parts of the brain. And that's a huge advantage. That's really been a very exciting, it really brought us into a new era of neurosurgery as far as I'm concerned. So if we look back now and we start to apply this to psychiatric disease, so the previous area of psychosurgery was marred by relatively poor scientific rationale. They didn't quite understand what they were doing. They were very imprecise about how they did the surgeries. There was really no great evaluation just to decide who was the appropriate patient, or once the surgery was done, how do we measure and make sure that we are overall not doing harm, that we are treating patients in a way that helps them. And so as a group, all individuals in the U.S. and throughout the world who are doing this are adopting very stringent criteria for thinking about bringing this kind of DBS surgery and applying it to psychiatric disease. And so the key elements that we think about in treating patients, so when do we treat? Does anybody who's a little bit depressed, should they get a stimulator? Probably not. That's a lot to do to somebody. But if the severity is so much that the patient is continually suffering, it's chronic, so that despite the fact that you're treating them, they are continuing to suffer over a long period of time, it is disabling, and it is resistant to really appropriate treatments that fall short of surgery. So surgery is still going to be a last resort, and they will have tried everything else, whether it's ECT, medications, etc. And a number of collaborative groups have formed in the treatment of OCD. This is a set of guidelines that an OCD group has created. There's been now an international guideline forwarded by the World Society for Stereotactic and Functional Neurosurgery, of which I'm a part. And everyone has agreed on rules basically like this, that you do this only with a combined group of experts. You do it in a center where you have IRB approval. You treat only candidates who meet the criteria that I showed you of severity, chronicity, disability, and refractoriness. It's all done with the advisement of ethicists and done very carefully. And so what are we doing? So I'll show you here. So this is the model of the basal ganglia. This is now I'm going to give you sort of a more refined model of the circuit that we're treating. So this is what we've been doing in motor disease for a long time. So if you see here, this is a sort of the wiring diagram for the brain that we have now, and it involves elements that may be familiar. So here's motor cortex, here we go, motor cortex. This is sort of these deep structures of the brain that sit sort of right in the center called the basal ganglia, the thalamus, which is a switching station for all the information coming through cortex and going back to motor cortex. And it makes a circuit that kind of regulates movement. And because we've come to understand that, we now have targets. So each of these nodes in that circuit have been targets that we've used for deep brain stimulation in movement disorders. As we've learned more about the structure of the brain, we've seen that there are parallel circuits. So there's a motor circuit here, but there's also a preparative circuit or a cognitive circuit that may be important in OCD, and a limbic circuit that's important in depression. And so each of these has targets that we've started to discover that you can use here. And so here are all the places that people have started to target. And it sounds strange to think of these two things together. When I first heard, well, we're treating movement disorders and now we're going to just sort of expand that into psychiatric disease, I thought, well, what could be more different than a tremor and OCD or a tremor and depression? These seem, in my mind, dramatically different. But what we've come to understand really is that in some ways there is a continuum of behavior that begins with things that are very simple, like tremor, and extend all the way to things like schizophrenia, that these are all combined. And in the brain, they are structured in a way that they are similar and exist in these parallel circuits that I've showed you. To convince you of that a little bit, I'm going to show you Tourette syndrome. So this is a patient with Tourette syndrome. What I want you, I'm going to show you just part of this video to begin with. I've shown you the dystonic patient that we treated with DBS, and that's a patient with these forced contractions that she cannot control at all. Tourette syndrome looks a lot like that. So this is a gentleman who has these undesirable tics that intervene in his motor activity. The one difference is that there's a volitional component. So most patients with Tourette syndrome who have that disease, they say, I can control it for a little while. I can actually resist a tic that might be coming. But I feel this urge to tic, and when I do finally tic, it's kind of a release. It's almost a compulsion to have that tic. And so people have looked at Tourette syndrome as being sort of at this interface, as you're going from motor disease and extending that into psychiatric disease. Tourette's is somewhere in the middle, and I'll show you what that looks like here. So this is a gentleman. He was not treated at our institution. I think he was at Case Western, but you can see, and can I do, I don't have the audio here. You can hear there are vocalizations with it, so he's kind of grunting each time he has one of these tics. Okay, and I'll show you a little bit more of that in a few minutes. So Tourette syndrome was really the first of these diseases that was treated with DBS. So this began sort of in the late 90s. People decided, well, if we can treat dystonia with this, why can't we treat Tourette syndrome? It shouldn't be that different. It maybe has some psychiatric components, but it's not really different in some senses. And we had at that time fMRI data, so functional MRIs that showed us that were particular parts of the brain that were altered during tic, and particularly in the thalamus, and something called the centromedian thalamus. That was a target that could be potentially linked to it. There was an old literature, so in the area that I showed you before of stereotactic surgery, people had tried to treat Tourette syndrome. None of that had been very well recorded or very well documented. But there was one target that seemed to be promising, and that was this area, the centromedian thalamus again, and that seemed to match up with what we knew about the fMRI. So starting around the turn of the century, people started to stimulate there, and so you can see these are the first surgeries where they put electrodes in a couple different places, in the thalamus and also in the GPI of the basal ganglia. And to date, there have been now 35 studies of patients being treated for Tourette syndrome with various targets. Again, because you have a circuit, you may not need to pick one place. There are different nodes in that circuit that may be responsive. And overall, people get a 50 to 70% reduction in tics in patients who otherwise could not be helped, who had failed all the medications, who had undergone every kind of behavioral therapy and have not improved. So let me show you this gentleman again. And I wonder if I can get sound for you guys. So you can hear the grunting that he has with it. So this gentleman was really quite disabled, and then here, he's had a surgery with stimulators, I think placed in GPI in his case, and you can see how dramatically. He's almost too good. He's got kind of a swagger. I mean, it's almost like a James Bond-esque sort of, it's pretty impressive. But it really did show us that we're able to intervene in these diseases that exist at this borderland between psychiatric and movement disorders.
Is he completely healed?
My understanding of that gentleman is that he was essentially completely healed and that this was maintained. He was on Oprah. I mean, this guy really was kind of a wonder story. Not every patient is that well healed, and I think if you look at everything that I'm going to show you here, you'll see that this helps a lot of patients that otherwise can't be helped, but it tends to stop at around 60% of those patients. There's still a group that even with these surgeries are not improved. And that's what we're trying to understand. We're trying to figure out, well, what is it that makes one patient respond to this and one doesn't? So we're not 100% there. Moving on to OCD. So OCD, again, if you take one step further towards psychiatric disease, you get into OCD. So here patients don't just have these motor compulsions, they have got obsessions and compulsions and all of the things that you've seen sort of, with OCD in the media. It's quite common, so 2 to 3% of the population have OCD. It's enriched in a neurosurgical population, so patients who go into neurosurgery tend to be more OCD than other groups probably. There are 3 to 7 million Americans who have this disease. And although, again, medications work for most of these patients, there's about 10% that are refractory. So even when you do everything to those patients, they still have the OCD. And in the most severe patients who can't go out of their house because they are checking and washing and can't have a job and have done this for years, those are the patients that come to us and we consider these types of therapies. So it's the worst of the worst, patients who really have failed everything else and whose quality of life is so poor without surgery that we would consider something like that. And so there's also a dramatic, social and occupational loss. $8 billion is an estimate in the U.S. There have been a number of PET and SPECT studies that demonstrate that different parts of the brain, again, focally are related. Orbital frontal cortex and the pathways from the basal ganglia to orbital frontal cortex seem to be the most consistently implicated. And so for that reason, a number of groups started talking about the anterior capsule. These are pathways that go from the kind of switching station, the thalamus and the basal ganglia, out to orbital frontal cortex. And I won't go through all these graphs, but basically what it shows is that if you take a small group of these patients, and there have been a number of studies at this point that demonstrate it, you can put electrodes in this part of the brain here. So these are deep brain electrodes. This is what it looks like on an MRI. The MRI doesn't show the metal very well, but it shows a little gap where those metal electrodes are. These are made of platinum. And by inserting this rather large electrode in that pathway, the anterior capsule, you can again jam the signal that is causing this aberrant behavior, and you can see pretty significant differences. And so here's an example. This is an individual who has very high, there are standard measures of OCD, something called the Y-box score, the Yale-Brown Obsessive Compulsive score. And what you see is that high 30 is you can't leave your house bad. And he undergoes surgery, and it pretty much stays that way for a few weeks. And then as stimulation is maintained over time, he tends to get a decrease. And with that decrease, you tend to see this is now your measure of functioning. You can see that he improves his ability to function, to go out of the house, to do any number of things. And this is what we see in the majority of these patients, that you can have pretty substantial improvements in your Y-box scores and in your functionality with stimulation. So a number of studies have demonstrated this, again with about 60% success rate. And it was enough that in 2009 the FDA approved the use of deep brain stimulation to treat OCD. It was approved because it was still a relatively low number of patients. It wasn't a huge number that underwent surgery. What they said is we're going to do it on something called a humanitarian device exemption. We don't think that there are, the number is 4,000. If there are less than 4,000 patients in the U.S. that are bad enough that they would need this surgery, the FDA will say, okay, we'll give you a humanitarian device exemption. You can go ahead and do it, but we're not going to require you to do a huge study that might have hundreds or thousands of patients. And so that's the status of it today. It's being done very rarely. Some insurances will do it, some will not. But it is quite useful in patients who can get it. And here, if you look at all these studies together, so this is I think there are a total of 7 studies now that have undergone it. And all of them you can see have about, if you average them, about 60% response rate. It's not a huge amount, but patients improve pretty substantially. Probably the psychiatric disease with the greatest impact, the highest frequency and the most disability is depression. It is by far the most common disorder in psychiatric disease, and it leads to close to 1 million suicides a year worldwide. So it's a huge public health problem. It's also tremendously disabling. Even people who are not suicidal, often cannot function. The patients who are most severe cannot leave the house, cannot maintain a job. And so for these patients, it's a huge disability. Although most patients respond quite well, we have today SSRIs, Prozac, etc., that work extremely well for depression, but there's still a substantial percentage of patients that will not respond, and we typically will try 3 or more of these drugs, and if they fail that, they'll get electroconvulsive therapy. But you're still left with a very large group, about 1 million Americans altogether, who simply will not respond to any of the great drugs that we have for depression. And so for those patients, there's a high suicide rate in that group. These are the patients that could be considered for this surgery. And so again, in this disease, there have been a number of studies, all small studies. You can see sort of 7 to 20 patients that have been treated in each one. And they've tried a number of different targets. So the medial forebrain bundle, that's a bundle of fibers that run through the midbrain that link all these circuits, something called the subgenual cingulate, which is a part of that limbic cortex that I showed you at the beginning, and then different other targets sort of in that base switching station in the brain. And each of these has shown fairly substantial improvement, again, in about 2/3 of patients in treating depression. People have also begun to sort of turn these things on and off and see if there's some benefit. So they blind these patients. They don't tell them whether the stimulator's on or off. They turn them on, they turn them off, and see whether the scores seem to vary with it. And so the scores that are used are something called the Hamilton Depression Score and the MADRS, the Montgomery-Ashburg scale. And what you see is that in each of these patients, they tend to improve when the stimulator's on, and then if you turn it off, they typically have a recurrence of their depression, and then it gets better again with stimulation. And that's true whether it's the nucleus accumbens, which is one of the targets here, the inferior thalamic peduncle. They showed something very similar in that study. There's been one patient treated with habenula stimulation, which is a very obscure tiny nucleus in the midbrain. And then the largest study has been something called the CG25, or subgenual cingulate area. And this, I think, is the one that probably has the greatest energy behind it right now and the greatest evidence. This was started in Toronto by a group, Helen Mayberg and Andres Lozano. And what they demonstrated, what Dr. Mayberg had demonstrated, was that if you take patients who have depression and you compare them to normal patients, what you see is that there is a particular area of activity right here in the brain. You can see that's all lit up. It's bright red. And that area seems to be extremely active if you're depressed and if you treat the depression in patients who can be treated, often you can compare that and say, okay, we gave this patient medication, did they get better? And what they show is that sure enough, this area turns off. And so she saw this in a number of different studies, whether it was by medication, by behavioral therapy, counseling, etc., by ECT, and all of them seemed to show that this area was preserved. And so that suggested to her and to Dr. Lozano that, well, couldn't we just stimulate this area to alter its function, to sort of turn it off reversibly? And so this was the genesis of those first studies where the patients got stimulators placed right, the tip of it is just in that region there. And here again what you see is that there are substantial improvements here in the Hamilton Depression Score, and that it occurs in about a month after the surgery starts. So it doesn't occur, it's not immediate, it's not like the tremor that you sometimes see where you turn it on and the tremor goes away, but over about a month, depression seems to be altered by stimulation. And with that, they were able to prove to themselves using PET studies that sure enough, the areas that had been hyperactive, the CG25 area, is now hypoactive, is turned off by the stimulation. This is a graphic. The most recent study is this medial forebrain bundle, which is a sort of a very powerful bundle of fibers that project from the midbrain all the way out to the frontal cortex. And that seems to have been, this is the first study that's shown greater than that 60%. They seem to have about 85% response in this target, and the response seems to be much faster. It happens in the first week. So that's, I think, sort of on the frontier. That's just been presented in the last year. We haven't tried that one yet. But depression really seems to be, I think, the greatest potential impact that this type of surgery could have, because so many people are disturbed by it. And in the patients that I've seen who have had this surgery, these are patients who had not left their homes in 10 years, had the surgery and have now gone out and they've gone back to work. One woman I treated had started her own business. I mean, it really can make a dramatic impact. What's also interesting is that this is letting us really understand an area in a reversible way. Instead of lesioning things like they did 50, 100 years ago, we're able to go in and record from these cells and learn something about that part of the brain and then stimulate it on and off in a way that lets us really examine the function of these parts of the brain in a meaningful way while we're providing a real benefit for patients. So I think we're really sort of at the beginning of what's going to be a very interesting era in neurosurgery of exploring and understanding the brain and treating it in a more rational and less damaging way. And so that's where we are. And so I'll just leave you with some conclusions and then I'll take questions. So, I think DBS is going to start to be a bigger contributor. This is really very rare surgeries that we're doing right now. We do 1 or 2 a year. But as we understand it, we do it more safely, I think this is going to have a bigger impact. And I think the things we're doing in this era are that we're being more rational about the way we approach it. We're trying to understand these things scientifically. We're being very circumspect in the patients that we choose. And we're doing that with a team of individuals that really review every aspect of this patient's care. And this is our team here. It's a multidisciplinary team that's made up of psychiatry and neurosurgery and neurology and bioethicists, et cetera. And it's the combined work with all of those people that makes this work possible. So I'll take questions. I guess right here.
Could you explain how a seizure starts and stops or doesn't stop?
Sure. Yeah, so seizure essentially, if you think about the brain, all parts of the brain, every neuron in the brain is doing its own thing. It's like people in a city, everyone's doing their own job and getting things done. What a seizure is essentially is when a group of cells start to fire together in unison. So one cell triggers another, which triggers another, and there tends to be a circuit that is created that keeps itself going. So, cell 1 stimulates cell 2, stimulates cell 3, which goes back to cell 1, and then that group is firing, and pretty soon they recruit more and more cells. And as you have that, then a large area of the brain, or even the whole brain, can start to seize in unison, the cells firing in unison. And so that's what a seizure is. And it tends to happen when you have some scar tissue or some abnormal tissue that allows this kind of a circuit to create. What we're beginning to understand is that, not just epilepsy, but many of these diseases may be similar in the sense that you have suddenly a circuit that is sort of run amok. In depression or OCD, it may be a more isolated circuit. In movement disorders, all of these things. It may be a smaller circuit, but it's the same kind of idea. Instead of firing the way it should, it is triggering itself and running in a circle and getting ahead of the rest of the brain in a way that causes malfunction, basically. Okay, a lot of people, all right. Over here. Yeah, please.
There are cases where some patients would be unable to give their consent or withhold their consent because they just don't have the ability.
Yeah.
Are there instances where the person responsible for that person can give the consent?
In the psychiatric realm, people have really stayed away from that. That has been the great fear, is that you would, especially in an era when these things were damaging, people were very worried about giving consent for an individual who might be so disabled, schizophrenic, they can't give their own consent. So in psychiatric disease, we have essentially insisted on patients who are able to give their own consent. For some of the movement disorders, things that are similar, you may have a child with bad dystonia, and in those cases we do make exceptions, again with a very careful, there has to be a specific guardian, and we're very, very sort of circumspect about the process, but in those cases we do sometimes have someone else give consent.
It seems to me that some of the patients who most need this would be unable to give their consent.
I think the most severe that's true, and I think we're still at a stage where we are learning about this. I think there may come a time when it's sensible, say, to treat people who can't give their consent, but probably not until we know this so well that we can predict, okay, this is what's going to help, and this is when it's not going to help. That's a good thought. Back there.
In the stimulation procedure, is there any pain to the patient?
We do our best to keep it pain-free. Many of these surgeries are done awake, actually, because especially with the movement disorders, you need to have the patient's response to know that you're not getting side effects, that you're getting rid of the tremor, etc. So it's something like going to the dentist. You numb up the scalp with lidocaine, and then the patient goes through it awake. It's not painful, but it's like being at the dentist. It's not fun either. It's a little uncomfortable. Yeah, right here.
Is there a genetic factor in these mental illnesses?
There certainly is, yeah. Sure, yeah. So the question was whether there are genetic factors in the psychiatric illnesses, and there are certainly genetic factors that are increasingly being understood. There are some diseases that there's a heavy genetic contribution, others where it's more sporadic, but there probably are families where depression is common, etc. We're just beginning to understand those. Yeah, back there.
A case of a young adult with autism that suffered from many seizures, and brain stimulation was tried, and then the result was that they felt that there were too many areas of the brain that were stimulating seizures, and it was not effective. Does that happen often, or is that an isolated case?
Sure, yeah. So the question is, in an individual who has been treated essentially for epilepsy, for seizures with stimulation, are there times when you can't treat when there are too many areas? It's generally true. So epilepsy surgery is sort of a related area. Our goal with epilepsy surgery, typically, the first thing you look for is an isolated focus, one spot in the brain that's misbehaving that you can remove. In the absence of that, and that's sometimes the case, and that those patients do well, sometimes you don't have a single area, and that's when you tend to look to stimulation as a possible treatment. There are different kind of stimulators that are available today and are being tried experimentally. The most common is vagal nerve stimulation, which is not stimulation of the brain, but stimulation of a nerve in the neck that is wired to the brain. And that tends to reduce seizure number. It rarely gets rid of seizures completely. The next generation of therapies are deep brain stimulators that are with electrodes positioned in the thalamus. Again, with seizures, they tend to follow predictable routes. So you have this recurrent firing, but it tends to stop off in something called the anterior nucleus of the thalamus. And if you can stimulate there, you may be able to block the seizure from spreading. It's not been perfect. It's a better opportunity than vagal nerve stimulation. Do you know, is that the kind of stimulator that they had, a deep brain stimulator? Or? Yeah, we're getting better at it, and I think the next iteration of these devices will be better, but they're not perfect. Question? Yeah.
Acting on her genetic question, do you have any feel of the percentage of all these patients that contribute directly from genetic source?
That's a good question. I don't know the precise numbers. Our psychiatrist would know better what percentage of depressed patients have a genetic linkage. It doesn't tend to impact so much on this treatment. This treatment, again, is reserved. We don't have genetic treatments yet for these problems. And so even though some we understand to be, it's just like tremor, we know that there are families in which tremor is very common. There are some where it's sporadic. They seem to respond about the same to stimulation. So we don't use that as a measure to decide whether or not we go to surgery. It's simply part of the underlying causality. Yeah, question?
Can you comment on TMS?
Yeah, so there's something called TMS, transcranial magnetic stimulation, which is related to this. So this is a non-invasive therapy where you essentially use a magnetic coil that's held over the scalp, and that causes electrical activity in some part of the brain, typically on the surface. That has been approved for use in OCD. It's been tried in depression. And so there are centers that are doing that. It's typically done by psychiatrists. It's related to this. We think it really acts on the same circuits, and it's simply a different way of intervening. It has some advantages. There's no surgery. You don't need to see a neurosurgeon, which is a big advantage, I think a lot of my patients would say. But the downside may be that it's like ECT. It's only temporary. You get a treatment. There will be some patients, I think, that do respond to it, and that's the right choice for them. There will be some patients that probably get that, and after several treatments are still having the problem, and they may be the ones that end up getting surgery. But that's a good question. Yeah, question?
There's been some recent information about concussions, particularly with football.
Mm-hmm.
What happens to the brain, say, with several concussions?
Sure.
How severe is it?
Yeah, concussions are a contributor to really all of this. So certainly depression is tremendously enriched in NFL players and in other patients with concussion, probably because you are having shearing of white matter tracts that are in these same circuits, the passages from the base of the brain out to the orbital frontal cortex and such. And it's as variable as every head injury is. I mean, it's hard to know. You can't take two patients and say, okay, which of these will have the depression based on their concussion? But we are understanding that those are increasingly risk factors for these types of problems: depression, movement disorders, Alzheimer's. I mean, all of these things seem to be certainly worsened by head injury. So I think we're more sensitive to that now. Yeah, question there.
Are these stimulations done or repeated, or at one time?
So stimulation, the way it is conducted, I didn't describe it well. So you put an electrode in the brain and you wire that to a pacemaker that typically sits in the chest here, and that essentially runs continuously. So you run at about 130 hertz indefinitely, and those batteries run out every 5 years and you have to change them. There are some new therapies that are starting to think about smarter ways. If you think about it, that's the dumbest way to stimulate the brain. It's just a regular 130 hertz signal. We're starting to have devices that are going to listen to the brain, that have a recording electrode there and detect the activity and then respond to it in a way that's a little bit more measured. But those are sort of the next generation that are up and coming. Yeah, right behind in the back.
I would like to ask about the man who was treated for Tourette's.
Yes.
Was he conscious of the improvement in his function, and was it permanent?
Yeah, I believe he was. He spoke about it on Oprah, so I know that he was very cognizant of it, and he spoke very eloquently about what a difference it made in his life. As far as I know, I think he was. The last I had heard, he had been followed 5 years and was still having improvement. All of these diseases, for the most part, they are permanent in the sense that you can continue to resolve the deficit with stimulation, but the stimulation does not tend to cure the disease. It doesn't tend to get rid of the Tourette's or get rid of the Parkinson's. If you turn the stimulator off or you take the battery out, those symptoms come back. And so we are persistently intervening in a disease process. Well, over here, yeah. There are several centers that are thinking about just that and have identified targets for it. I'm not aware that there's been any trial just yet, but I suspect that it's coming. Oh,
That you can get over by staying busy after?
yeah, that's a good question. So the question is, are there types of depression that you can treat just by staying busy? And I think that I think the first line of therapy in depression is essentially behavioral therapy, which is essentially altering your activity and your behavior to treat your depression. That's probably one of the most effective ways of treating a simple depression. When it gets beyond that, then you have medications, and when it gets so extreme that all those things don't work, the activity, the medications, ECT, et cetera, that's when we think about surgery. But it's with those things as well. Back here.
Does this process hold any promise for bipolar disorder?
Yeah, so bipolar disorder has been treated as a subset of depression, and people have not looked at that specifically. So in that first study that I showed you in Toronto, 20 patients, I think there were 2 or 3 of those were bipolar patients, and one responded, one didn't. I forget what happened to the third. We don't have the numbers yet to know whether this is going to be different for bipolar patients, whether they will respond better or less well than your regular depression patient. But we suspect that the systems are similar and that we probably will be able to intervene in those patients eventually. Yes?
In that same vein, what about autistic patients?
Yeah, autism, I think people have talked about whether there would be a way to treat that. The problem with autism is that you know, all of these things work great when you have a spot in the brain that you can identify as kind of the principal culprit. Autism seems to be a more complicated thing where the inherent connectivity of different parts of the brain is limited. And so I don't know that we have a simple way to address that just yet, at least until we understand the disease better. Yes, question?
What about Parkinson's?
Parkinson's is easy, finally. Okay, so Parkinson's really was one of the very early indications for deep brain stimulation therapy. And we've been doing that surgery since it was established in the 80s in France. It's been treated here at Vanderbilt. We've been doing it since '98. It's the most common reason to do deep brain stimulation surgery. And it works extremely well. So patients who get, it typically works best. So patients who have Parkinson's disease will typically do quite well on medication right after their diagnosis. So you give them the Sinemet, the L-Dopa, and patients feel much better. About 5 years later, they start to have fluctuations. They have on periods and off periods and tremor that isn't well controlled. And in those patients, the stimulator essentially does what the medication does. It slows down that circuitry in a way that is adjustable and reversible and constant, which is better than the medications. So it works quite well in Parkinson's. Yeah. A question right behind.
How about RLS?
So RLS, I don't know that anyone has treated. I'm sure somebody has, but it's not one of our common indications for deep brain stimulation therapy. It is related to Parkinson's disease in some ways. It's related also to dystonia, and in those diseases it does work well. It typically responds pretty well to some of the medications like Mirapex that can improve it. And it's certainly something we would consider if a patient had RLS so severe that the medications didn't work. It's in the realm of things that someone might try. Yes, question?
How does ECT work? I'm going back.
Yeah, no, so ECT is, essentially what you're doing. So electroconvulsive therapy. The question is, how does ECT work? And again, it is no one knows exactly how it works. It is a very blunt treatment. What you're essentially doing is you're running current through the brain at a pretty high voltage, and you're essentially causing a seizure with direct electricity. And that seizure causes firing all over the brain, and what we understand about it is that it builds up neurotransmitters. And so for a long time they thought, well, simply what you're doing is you're acutely activating the serotonin system, and you're leaving serotonin everywhere in the brain, and that transiently improves the depression. The same way that SSRI is a serotonin reuptake inhibitor, so it essentially also increases serotonin. And so the thought was that you're doing very bluntly what you can do more precisely with a medication, but it's still in some sense the gold standard. When a patient really is not responding to all the medications, ECT is tremendously effective in treating those patients, and it's still something we would consider first before going to surgery.
Doesn't it leave some brain damage?
It does cause trouble with memory, and so that's an important caveat to it. But it's effective. Yes, question there. Senile ataxia. So gait in general. So ataxia and problems with walking. The question is whether senile ataxia responds to stimulation. That is an area that has not shown tremendous response to DBS. We still don't understand those mechanisms well. There is one target called the PPN nucleus that has been tried for a variety of diseases that have very severe ataxia, and the data is sort of equivocal. Some studies show that it's effective, some show that it's not. It's not really clear.
I know there are more questions, but I have to do my usual thing. That hole is going to open up under me one of these days. But let us thank Dr. Menon for the